Anthracyclines like adriamycin and epirubicin are good chemotherapeutic agents which improve the long-term survival, especially in breast cancer. But a small number of them develop cardiotoxicity, which is less with epirubicin than with doxorubicin, adriamycin, on a milligram per milligram basis. The chance for cardiotoxicity is more in the elderly and those with pre-existing heart disease. Concomitant radiotherapy and use of cyclophosphamide also increase the risk of adriamycin-induced cardiomyopathy. The total cumulative dose is also an important determinant of risk. Conventional risk factors for heart disease like hypertension and diabetes mellitus also increase the risk of congestive heart failure with anthracycline therapy. One study found the risk of congestive heart failure with epirubicin to be about 5%. The risk becomes more significant in those with early stages of cancer who are likely to be cured of the illness. Trastuzumab is useful for chemotherapy of breast cancers which are HER2, human epidermal growth factor receptor 2 positive, which could constitute about 1/5 of cases of breast cancer. Untreated, HER2 positive cases have a poorer prognosis than negative cases. Adding trastuzumab as an adjuvant chemotherapeutic agent for 1 year has a significant impact on improving survival in HER2 positive breast cancer. There is a medium risk for development of cardiotoxicity with this monoclonal antibody. Most often it takes the form of asymptomatic left ventricular dysfunction documented on echocardiography, while rarely clinical heart failure may also follow therapy with trastuzumab. Severe heart failure or death is reported only in 0.6 to 4% in different studies. Risk is likely to be higher in those who have received doxorubicin therapy earlier. Trastuzumab causes type 2 cardiotoxicity, which may not be dose dependent but reversible. HER2 receptors present on the myocytes may have a role in cardiotoxicity. Type 1 cardiotoxicity is irreversible and caused by death of cardiomyocytes through necrosis or apoptosis. Type 2 cardiotoxicity may be reversible as it is caused by cardiomyocyte dysfunction and not cell death. Long-term cardiotoxicity of anthracyclines is of type 1 with cell death mediated by free radical formation and hence likely to be irreversible. Androgen deprivation therapies for prostate cancer are bilateral orchidectomy and gonadotropin releasing hormone agonists. Androgen deprivation therapies can cause decreased muscle mass and increased fat mass, together known as sarcopenic obesity. In addition, they can cause decreased insulin sensitivity and alterations in lipids. They have also been associated with diabetes mellitus and cardiovascular disease risk. Oral immunomodulatory drugs, IMiDs, thalidomide, lenalidomide, and pomalidomide have a crucial role in the treatment of multiple myeloma. IMiDs, particularly thalidomide, is associated with increased risk of both venous and arterial thromboembolic events. Proteasome inhibitors have significantly improved survival in patients with multiple myeloma. They have been rarely associated with serious cardiovascular complications like congestive heart failure, hypertension, and arrhythmias. Highest rates of cardiotoxicity have been noted with carfilzomib. The evidence regarding cardiotoxicity of bortezomib is conflicting. Immune checkpoint inhibitors are a promising group of novel anti-cancer drugs. They are monoclonal antibodies targeting cytotoxic T lymphocyte associated antigen 4 (CTLA4), programmed cell death 1 (PD1), and its ligand PDL1. Two important drugs in this class are ipilimumab and nivolumab. Autoimmune myocarditis, which is potentially life-threatening, has been associated with immune checkpoint inhibitors. Antimetabolite 5-fluorouracil can cause coronary vasospasm and ischemia. Life-threatening cardiotoxicity is seen with a frequency less than 1%. Calcium antagonists like verapamil and nitrates may be useful in treatment of coronary vasospasm induced by 5-fluorouracil. Vascular endothelial growth factor inhibitors have been associated with increased incidence of hypertension, ischemic heart disease, heart failure, QT interval prolongation, and thromboembolism. Two important medications in this group are bevacizumab and sunitinib. Tyrosine kinase inhibitors used in the treatment of chronic myelogenous leukemia can cause atherosclerosis and other vascular problems like coronary events, cerebrovascular events, and peripheral vascular events. Pulmonary arterial hypertension has been noted in patients treated with dasatinib. Ibrutinib is a Bruton tyrosine kinase inhibitor effective against B-cell cancers. At the same time, it increases the risk of atrial fibrillation. Risk of atrial fibrillation has been attributed to inhibition of C-terminal SRC kinase. Here are the first set of journal references. Second set of journal references. Third set of journal references. Fourth set of references. Thank you for watching this video. Please subscribe, like, share, and post your valuable comment below this video.